ambulance wasn't going to be included at all. And then it took legs of its own as it came out of Ed and Labor Committee that it wanted at a minimum that there was some type of committee put together to study the issue for ground ambulance. And that's why you saw the language when it was passed in the Consolidated Appropriations Act had the actual ground ambulance language to actually put a committee together with certain parameters to study the issue to make recommendations back. On the air ambulance side, it was interesting the provisions that were actually put in. Some of them were aligned with what happened with other providers in the emergency space, but it had its own section. And there was a lot of parameters that were not applicable that happened to other providers. And then there were some nuances around the independent dispute resolution process if you decided you wanted to go into the baseball style arbitration. And I'll kind of walk through some of those nuances for you through this. And then we're going to take that and we're going to then look at what should we be thinking about from the ground ambulance industry perspective as we begin to debate this in the federal committee, and then to put together a recommendation through the process as well. I think it's important to note that as we talk about the No Surprises Act, is remember this is a act based upon payment. It is not a coverage bill. And so if you don't have air ambulance coverage or ground ambulance coverage, it doesn't impact coverages. So the insurance carrier can do and make changes with coverages. And I'll talk you through that was a concern and why there are certain reports that are being done. But just as a base premise, the No Surprises Act, it amends 4 points of legislation or 4 points of regulation. And that is under the Public Health Services Act. Of course, it's looking at the ERISA side, which has caused this issue to begin with, and that's about the self-funded plans. I talked a lot about that yesterday. We were talking about insurance contracting and understanding your market. Like 51% of Colorado is in a self-funded plan, which falls under ERISA, so they got to modify that. It's also modifying some of the provisions within the Internal Revenue Code that impact this, as well as, of course, if you're a federal health employee, it's also got to amend some of those provisions under the Federal Health Benefits Program. I think it's important to note in the air ambulance space that was lost in all of this is how workers' comp factors in the air ambulance space. Since states can't regulate rates and routes, even though there has been some precedent set in other states that has been looked like it's been taken to the federal court system where certain things have been upheld, and I know those things are continuing to be challenged. There is an issue here, and this is causing us some problems technically for the Ground Ambulance Patient Billing Advisory Committee. And a lot of people are why the committee has not been named yet. And it is because that it has the oversight of 3 secretaries. So the trifecta of Labor, Health and Human Service, and Treasury, with Health and Human Services taking point. But basically, you have to have agreement and sign off on pretty much almost every initiative that's going to be going through the process. And so as you can imagine, while they might talk and it might be government, they all run their own entities in silos. And so that is just an interesting dynamic that we see here. The reason why I talk about the implementation funding is because follow the money. The money usually gives you a lot of insight into the provisions within an act that have to be administered by the executive branch. And so they appropriated, or Congress appropriated, about $500 million to implement the provisions within the No Surprises Act. And so when you think about it from that perspective, think about that this is going to be a heavy rulemaking process. And it has only started and only begun as they begin to implement the provisions. And a lot of this stuff is going to be through the rulemaking process, because a lot of authority was given to the secretary to implement certain provisions. While it was given some parameters, there's a lot of stuff that's open to interpretation. And that's why you're seeing some of this stuff begin to be challenged by the provider community as well on certain provisions that possibly are being implemented that may be straying from the intent of the act. Now, there are 4 key provisions that it's looking at. in general rules and in generalities, it's really taken the patient out of the middle now. And it's basically saying you have to treat the patients like you would if they were in network. There is parameters around how that payment will happen, and then allow the providers, if they don't like what happens, to dispute this through what they call a baseball style type arbitration process that is binding. So once the arbitrator decides on what it will be, and I'll explain some of those provisions through this process in subsequent slides, it basically then indicates that is now binding to whoever the winner is, and basically loser pays all. And so the last point that I want to really focus on for you guys here is what it also is talking about. And this is what we're beginning to see happen through all these transparency rules, but it basically is requiring providers and health plans to assist patients in accessing healthcare cost information. And so to get at what the actual qualifying payment amount is, you saw that the hospital transparency rule came out. That had a lot of controversy. When the Trump administration actually began to implement it, it was challenged by the hospitals and others on the data. It was upheld within the Supreme Court. And so basically they agreed that, that CMS had the authority to mandate that hospitals have to post all their rates, have to post their contracts, the rates that they get paid, and vice versa. And there was also a transparency rule that came out for payers. And so the first wave of that implementation happened on July 1st of this year. So technically, if you go to every healthcare site or every payer site, you can go to Blue Cross Blue Shield, or you can go to United Healthcare, and you can actually download a file. Now, the first file is a file that is on that you really going to have an aggregator or programmers go in. It's what they call a JSON file. And you can actually download data. You can actually begin to get it all by the NPI number. So a lot of us, for instance, like our technology company, we actually have our programmers going through that and kind of working through, and I can actually go down granular to an NPI number. I can look at your HCPCS codes number, and I can tell what they're contractually bound to. We're starting to see some things come out of this data, specifically around air ambulance, as we start to maneuver through this. That, for example, we have an NPI number that is assigned to a dentist that also has contracted air codes with it. Well, that's a little suspect. How is that happening that an air ambulance, HCPCS codes are related to an NPI number by someone who is a dentist? That would be abnormal. So there's some challenges as we start to look in the data that might be an indicator that we might see some gains happening amongst the health plans that are contracting codes that they know in NPI, or that they know that a practitioner probably doesn't care about those codes because they don't do it, but they're signing that they're in network with something because of the way the rules are. So we're starting to get an insight into this data as this happens. So what does that mean? What is this about the No Surprises Act as we talk through that? So most of you guys know that you have to look down the road and in the future of what are we looking at? What is all of this beginning to tell us? The No Surprises Act is just another, step towards leveling the playing field and bringing people to what I call is going to be universal healthcare coverage anyway. And so when you begin to take out from the healthcare provider's ability to negotiate, because we have all this transparency of the data, guess what begins to happen? The market starts to reset. We start looking at different things through the process of saying, okay, it's very interesting. Now I know my neighbor is negotiating a certain rate now because the data is there for us. Now, right now in the payer side of it, you have to have programmers or somebody to go in there and aggregate, pull all these files, go to every single website to download it. So for example, like United Healthcare, when they posted all of their information, they did it by the actual plan level. So, 53% of the employers. So every JSON file is an employer. And so you have to take those hundreds of thousands of employers, aggregate the data together. So it's complicated right now for the aggregators, but by July of next year, the mandate is that every payer has to have a user-friendly interface that any patient, any provider, any stakeholder can actually go to their website, key something in to understand it. So think concepts that like data eyesight, think concepts like, and I'll share this with you later, like fairhealthconsumer.org, where it's a user-friendly interface that anybody can go in and look. So the game's going to change in the next 18 months, guys. In the next 18 months to 2 years, the industry is going to be looking different. Healthcare in general is already starting to look different. And it's on a very fast pace as this data becomes more and more transparent through the process. So this is what it's doing. This is a lot of the provisions within it. And we are the only entity that provides emergency services that is not included. So ground ambulance is over here on an island by itself. Everybody else is within the provisions of the No Surprises Act. Now, the one thing that I want to talk about on the base level is there's several reports that are due to Congress. And these reports were meant because they wanted to make sure that providers weren't starting to try to do workarounds around the act, and neither were insurers. And so what they wanted to do is that by January of this year, basically the FTC and the AG's office has to provide a report back to, or I'm sorry, HHS has to report to the FTC and the AG's office on any effects of this act to the integration, to access of care, things like that, or the cost of doing, if any cost related to the implementation of this of the NSA. The GAO by 2025, though, has to give a report to Congress and to the secretaries in the executive branch on, was there an access to premium? Did the premiums increase or decrease for insureds? Was there also a network access issue? What happened to out-of-pocket costs? As you know, they don't really have to share this. This is 2025. There's a lot of damage that can be done over the next few years before this gets to Congress. Also, they've got to talk about network adequacy, and that is going to be key. Ground ambulance, currently there is really no federal entity that really even advises or does anything on network adequacy. It's a very interesting conversation. Several of us are talking with CMS, Society about this. Is kind of opening and enlightening their eyes to, didn't really think about the network adequacy piece of it, which is extremely important for EMS and should be. And then also the independent dispute resolution process. So think about that. You're going to hear a lot about the IDR if you haven't already heard about it. If you're in air ambulance right now, you know a lot about the IDR and the independent dispute resolution process and some of the issues that we are currently having with the independent dispute resolution process. And so they've also got to report back to that and any potential conflicts or financial relationships that might be on their boards and things like that, that could be shifting when they make the decisions on the disputes or the dispute resolutions. So that's kind of a yes.
In the room, please. So, Asbel, when you speak of network adequacy, what does that mean?
So I'm going to go into that here in a general and subsequent slides. I'll answer that for you in subsequent slides from here,
okay,
Kim. But I'll talk you through what network adequacy, because it is going to be a discussion and a topic of discussion when we get to the ground ambulance and patient billing advisory committee. Network adequacy is going to come up, and I'll talk you through what that actually means. Because there's some stuff that you can do on the state level. So I'm going to delay that and defer that when I get to that actual slide. So let's talk to you about, and let's rewind and say, okay, we understand that it impacts all of the physician community. So the anesthesiologist, the radiologist, basically the hospitalists that are not employed by the hospital, as well as emergency physicians and others that operate in that emergency space. And there's also provisions about air ambulance. The reason why we're going to look at that premise as a foundation for ground ambulance is because typically when people think ambulance, they think air and ground, and currently that is how our fee schedule is set up. So most people condense all that together. We have not bifurcated ourselves from them. However, it was interesting that they only wanted to address air ambulance in this bill and allowed a lot of us who advocated to keep ourselves carved out to work this piece through. And it was really because we did a very good job at selling and advocating on the ground ambulance side about our local regulatory control. And that they couldn't wrap their head around, and they really wanted to make sure that if they included us, that there was not any unforeseen consequences to including ground ambulance, even though there were entities like the Brookings Institute, which is kind of a quasi. I hesitate to say that it's bipartisan because it really isn't, but it's a advisor that kind of looks at different payment systems, makes a lot of it's kind of like the Commonwealth Fund, things like that, and it will advise, have even been saying you can include them. We've done our due diligence that there really won't be an access to care issue, things like that. And so I want to focus on air ambulance because there's a lot of things that happen within air ambulance that we can take lessons from. Some good things that they did in their provisions to get this implemented, and some things that we may want to try to stay away from. So the key provisions that you should look at are a little different in some of the things that maybe is not in the other pieces of the NSA that also are correlated. Is the one thing that came out of this that was actually a good thing is my third bullet point, and that is now it's a direct pay law. So there is no more of this that insurance carriers can send the payments to the patient for out-of-network providers. All payments now directly have to go to the provider. So if you're an air ambulance, basically all payments or denials have to be sent directly to the provider within 30 days of receipt. Okay, there are some issues that we're learning now that they're not processing within 30 days. There's a lot of complaints being made. CMS is addressing that for penalties, things like that. But currently, technically, in a real world, if they implemented this correctly, you should have a payment or denial within 30 days from the date that you send a claim. And that's a positive thing for the air ambulance industry. Other than that, it also talks about the cost sharing, very similar to it does to all other providers, that it has to be at an in-network as a rate that would be as a participating provider. Also talks about that it has to apply towards the patient's in-network deductibles and out-of-pocket maximums. And then the number 4 is where the controversy starts. And this is the payment shall be equal to the rate of what we call a recognized amount or the qualifying payment amount, and it has to be made directly to the air ambulance provider. So what is the recognized amount as it's currently defined in the No Surprises Act? And this is important if you're a ground ambulance provider, because this is what we're talking a lot about. And this is something that is probably going to be an area that's going to be hotly debated in order to get to consensus on what we would recommend as an industry on what this should actually look like. So the recognized amount falls into 3 different buckets. First, it is an amount that is specified in state law or is regulated by state law. So what this is telling you is if the state has a balanced billing provision already, it will take that amount will be whatever that state law says. Okay. Now there's some good qualifiers for it to happen. It basically your IDR, your arbitration process, if a provider disagrees with that amount, has to be binding. So whether it's binding in state law or it's binding somewhere else in state law, refers to a local law that binds it or mandates that whatever your city ordinance passes as the rate structure is what has to be paid. That could be considered binding as well. Or this definition of qualifying payment amount, and I'll discuss that in a minute because there is a definition of qualifying payment amount, or if the state has an all-payer model agreement. Currently, there's only one state that does. There's more states that are putting them together right now, but at the time of this, there was one state, New Jersey, that has basically an all-payer model agreement. And so that was basically saying that all-payer model agreement could stand. Now you're seeing some states really start to put together their own all-payer model agreement, which I find very interesting. It's being led a lot by the hospital and physician community right now, which is interesting to me. That basically it gives 3 different levels. For air ambulance, the qualifying payment amount is the only one that applies because of the Airline Deregulation Act. And because states cannot set rates or routes, this is where the qualifying payment amount comes in. And this is why you see so much controversy around it, a lot of pushback, a lot of discussion regarding the qualifying payment amount, specifically also from the air ambulance market. But the other 2 don't really apply to the air ambulance market right now. So let's talk about what the qualifying payment amount means, because this is very important for you to understand from the air side, because as the dialogue starts happening with the ground, we begin to understand, what does this actually mean? And should we be rethinking something else as a ground ambulance industry on what that qualifying payment amount should be? Now, but basically the way that it says it right now is it needs to equal, I'm going to say this in kind of layman's terms, it needs to be like the median contracted rate for a region. So think of it a lot like your Medicare localities. I'm just trying to give you some analogies. Think about it like your Medicare localities. And so depending upon what region or locality you're in for Medicare, your rate might be different and adjusted based upon a geographic, what they call the GPCI, the Geographic Productivity Consumer Index. It will look at it differently based upon if you're in Denver, if you're in Pueblo, wherever you're at, might have a different locality. Some states have one locality, some states have 15 localities, depending upon how big you are. So think about it like that. So it's going to say, take that look, and then how many in-network providers do we have? And then I'm going to take that median number and adjust it, what it was in 2019, adjust it for CPI for a few years, and I'm going to come up with a number. And that is going to be your qualifying payment amount. In 2023, it's going to say, take the number from 2022, adjust it by CPI, and that's your new QPA. Okay. And it just continues on like that over time. And so as you can see, this is very, very centered and centric on what would be identified by the payers, because most healthcare providers don't have access to the data like an insurer might have within it. So that's why you're seeing the transparency of the providers or the payers having to send their information out now, so it can be double checked, but still it is still a ways coming from that. So that's why you see all these other databases coming in line for us to kind of understand that piece of it. And so then he gets into the independent dispute resolution to figure that out. Now, the one thing that air did, because it's very similar to ground, there's not a lot of network providers in air, or there wasn't. There's more and more happening, but there wasn't a lot. So how do we know if you have to get to a threshold of having at least 3 in-network providers in a region in order for that plan to be able to use their own internal data and come up with the median number? What if there's not enough? What if there isn't any? Then what do they have to do? Well, then it goes on to say you take the MSA region or maybe the rest of the region of the state. So then you look at the whole state. Now, if there's not enough providers in the whole state that make up 25%, then it would move it into a census region. And there's 8 census regions, and it would basically take that census region. Now, I'm not really sure that that would be applicable. So for instance, in the census region, that's where Illinois or Chicago is, it's in the same area where Jackson, Mississippi is. Well, I'm not really sure that Jackson, Mississippi and Chicago are even relative in what they do. And so there's some flaws in some of that methodology. And so hence the reason why there's a lot of kickback that begins to happen as we start working through how do we challenge this data? What do we do with this data? But that is the QPA, and that's how median net number is defined right now currently. So leaves a lot of discretion to the secretary to come up with methodologies, and that's some of the stuff that we'll talk about here. So then you've got the QPA. Then there's provisions within it that talks about the independent dispute resolution process. So think about this like a glorified appeals process, but it has an arbitrator. And basically, it's baseball style arbitration. You give your offer, the payer gives their offer, and basically based upon some parameters that the arbitrator has to consider, they choose one of those, and whoever wins, that's the amount you get. And then the fees that you had to pay to the arbitrator have to be refunded to whoever the loser has to pay the winner, basically. Okay, but there are factors that differed for air ambulance because of the uniqueness of air ambulance from all other providers that provide or in the emergency continuum that they factored in. And this is something that we need to pay attention to as ground ambulance, because this is probably something that would be considered for us as well. So basically the IDR has to look at these different components. So think about it. They've got to look at it for the same service in the same geographic region. They have to look at the different ambulance vehicle types. They have to understand where the population density of the pickup is. So if it's in a very rural area or a frontier area or suburban area. And then it also has to look at, and this is what I was talking about yesterday, about that good faith effort by the parties to contract and the contracting rate history from the last 4 years. This is why when I spoke a little bit yesterday about contracting with insurance, why it's really important, the nomenclature that you're going to be using. If they reach out to you to start trying to come up or to try to get you into network, you have to be able to show, did I engage them? What I did, I've got to put stuff in writing, because this could become beneficial if we are ever put into the No Surprises Act. I'm saying when we are, not if we are, but when we are, that you've got a contracting history to show good faith efforts were done, but they basically just told me, take my rate sheet and you take it or leave it. That is not a good faith effort by parties to contract. So those are some of those things that we would kind of look at and begin to think, okay, if they did for air ambulance and made certain provisions for them, are there certain things that we need to consider as a ground ambulance? Now, there were some factors that they could not consider, and that was usual and customary and bill charges. That was a win by the payers. And then in order to have consensus, when all this was playing out at the 11th hour, they basically indicated as a win for the provider community is that the payers could not look at payment rates by public payers like Medicare, CHIP, TRICARE, things like that. So they couldn't use, a QPA could not factor in Medicare rates or Medicaid rates, etc. And then they also couldn't factor in what you billed or what your usual and customary charge was. So that is something that they cannot consider at all. And actually, if you put it in there, and that's one of your arguments, they remove it altogether. So that is kind of what, when on the air ambulance, that's at a high level. There's some other stuff as well that I'll talk you through, but that's at a high level. That is the contentious issues right now that's going on with air. So what is the impact of that today? And we're going to talk through, and then what we need to be considering, and this is probably where a lot of your questions are going to be answered. If not, we're going to have some healthy, robust dialogue here. So most know there's been several rules that have come out. The first major rule that came out, and they called it an interim final rule, or what we call an IFR. And so part one was establishing how the QPA is going to look and what the qualifying payment amount was. The very interesting thing that I found on the QPA was there wasn't a lot of controversy around what CMS did in that interim final rule. It was very interesting that when you talk to people at CMS or Society, they weren't hearing a lot from the provider community on that. Of course, it was an IFR with a comment period, and people submitted their comments or whatever through the process, but there wasn't a lot of like angst. You didn't hear a lot about it in the news, things like that. It just kind of went through the process, which I found interesting. But lo and behold, the interim final rule part 2 comes out. And it established the QPA as presumptive. And this is where the provider community went into an uproar. The Republicans on the House and the Senate also went into an uproar. And if you followed this, you saw a lot happening. That basically the rule that came out is that CMS took liberties that was not a part of the intent, that it was never for the intent for the QPA to be presumptive, and all other factors that they would have to show credible evidence of those factors. Otherwise, the QPA was going to be the final number. And that was not the intent. Those factors that I talked about back here, these factors should all be looked at on equal merit. That they shouldn't just take the qualifying payment amount as presumptive and then say, if you can show us credible evidence on all these others, then we might differ from the QPA if you can show it. Other than that, if it's not credible, and who defines credible, you're going back to the QPA. That was not the intent of Congress. And so this is where you saw lawsuits start to be filed. The first lawsuit was filed by TMA in the Eastern District of Texas, filing a lawsuit against them for a temporary injunction or for injunction. against that, against several provisions, not just that provision. And then following suit, the air industry also filed an injunction as well. And they also filed, for some other factor that they should be looking at the organizational types of an air ambulance provider as well, because costs differentiate between the two or what have you. And so this is where the controversy happened. You saw letters of Congress, members of Congress also send letters as well, that was never the intent of the No Surprises Act, and had they even thought that this would be liberally interpreted this way by the executive branch, that they would never have passed that provision with it in general as well. So who wins? Well, most people knew they really were operating without the jurisdiction to do that, specifically around the presumptive QPA. So the federal court did strike down the qualifying payment amount under that presumption in February based upon the TMA lawsuit. Okay. And so basically they had to go back and re-amend certain things. And remember, this is almost 2 months after the implementation date of the No Surprises Act for everybody. So this starting on January the 1st. Transports are happening on January the 1st, but there's still no independent dispute resolution process yet for providers to go through. So you can see what's happening here. Claims are delaying, claims aren't being paid right. There's a process beginning to happen on everybody's side. I'm just focusing on air ambulance. In April or May, Modern Healthcare actually published, based upon a study that AHIP did, which is America's Health Insurance Plans. It's where most of your health plans are part of an association. And then the Blue Cross Blue Shield Association published data that showed in the first 2 months of the implementation, they showed that the No Surprises Act had blocked almost 2 million bills already, which was more than what the CBO estimated would be the impact. So it's very interesting to watch what's happening here. It's basically blocking more than they thought and anticipated, and that's going to come down into some things that are continuing to transpire to this day. So it's important to note what the data is beginning to tell us. So the insurance plans are touting that this is a win, great. Less than 2 million Americans are not getting surprise bills that would have gotten surprise bills under this act. So this is a good thing for the consumer. But what about for the provider who is providing care to the consumer? This just recently happened with this news. So of course, CMS came back based upon the provisions. It was stricken down in July for the AIMS lawsuit, or for the air ambulance lawsuit. That was also vacated, or the same thing kind of applied, that the QPA was not presumptive anymore. You've got the AHA win on that. And so CMS went back and modified the rules to accommodate. Okay. So once the interim final rules have now became permanent, that has come out, AHA and AMA are now filing an amicus brief on the provisions based upon the QPA now. They're still got a problem with the QPA, which a lot of us do, and feel like that is still an issue. And so they think they've got some more support through the process. So you're going to continue to see these challenges as they continue to keep dropping these different rules as we go through this process. So this isn't going away, but it doesn't mean the No Surprises Act is not happening. Remember, the provision that is not in dispute, that Congress was clear about, is the patient is no longer in the middle. So you still don't have a recourse to balance bill a patient. If once you bill their insurance, you do not have a recourse to balance bill the patient for this. But we're still debating all this other stuff. So it's clogging up your AR right now, and it's clogging up a lot of people's AR, and it is causing issues. And we're waiting to see what kind of network adequacy issues it's causing. Is it causing people to get out of network with Medicare and Medicaid and others and just say, I'm just going to full private pay. So if you want to treat me, I'm going to be more in concierge medicine. We're seeing a lot of that happen as well. We're seeing anesthesiologists say, because there's notice and consent provisions for them, that is not applicable to air ambulance. Those are the things that we're looking at here. This is the next thing, that the timeline of your aging for air ambulance. Now, on the ground ambulance side, it's interesting to see, remember, all of these things are happening to others and not us yet. Though we're seeing our aging increase, we're not seeing it increase as fast as the other providers that might be in this process are seeing. I'm consulting with several air ambulance providers, and we are seeing a rapidly growing aging, moving much faster than what it was when we compared it to last year. And so technically, if you looked at the way that it was codified in statute, from the time of denial to actual resolution in a perfect world would be 127 days if you were going to let it go through this process. It's 127 days. Okay. So basically, we are not seeing that, just so you know. We actually, the IDR process didn't even open until the 3rd week of May. So if you wanted to dispute something and you're an air ambulance process, you really couldn't even dispute it through the IDR process until the 3rd week of May. So everything that you transported in January, February, March, April, if you were waiting for the IDR side of it, you may have had some partial payments by insurance carriers, but you couldn't even get them into the IDR process until the 3rd week of May. And because now they have got more than they can handle, they basically have sent out notifications at this point, CMS has, is that the IDRs cannot maintain the 30-day request. And so they're locking things down now. They are really paying attention to if people are actually utilizing the 30-day business or the 30 business day open negotiation side. Are you getting it within 4 business days or notifying within 4 business days that you want to go into this? If you wait to the 5th business day, it's declining that you can't go into IDR. And so basically you have no recourse at that point. And so they're starting to really ramp down on this because they are receiving more disputes than they anticipated. So it's going to be interesting to see how what this bottleneck is going to cause. There are already lots of us beginning to look at this and say, keep track of what the monetary amount is. Start making sure you're filing all the formal complaints right now. Don't leave it to just reaching out. Make sure everything is logged. Start looking at that piece of it, because this is reminding me and very reminiscent of when we had the ALJ issue or the administrative law judge backlog as an industry, not just I'm talking about healthcare in general, several years ago. And they had to go back and make settlements that a lot of people took from hospitals or whatever, where they paid like 70% of what was outstanding, kind of negotiated. This is kind of reminiscent of what's going on here. The backlog, the volume that's going into the independent dispute resolution process, people cannot, they can't handle. And many of the independent dispute resolution processes are no longer taking any more disputes themselves. They've like shut it off and said, we're done. We're not taking any more at this point. So it's interesting to watch what's going on. Good thing for the ground ambulance industry is we can watch this, learn the lessons, and then figure out what we need to modify. But if you're in the air ambulance industry, you're in the middle of this right now. And so what are you doing? How are you working your aging? And then everybody is watching to see what is the access points that people are having. While we've been seeing some bases close, it may not be causing an access issue. That's what we're talking about. We have not seen that yet. Looks like when a base closes, some other entity takes over that space, which is typically what we see happen. I know this sounds crass, but ultimately, unless people start dying, unfortunately, it's kind of where you're at right now. Unless the access shows that people are not getting served and they have major complications where somebody is going to die, something is going to happen, that typically will begin to then wake up lawmakers on where the pressure point is. So right now, this is what's happening through this. Now, if you're an air ambulance provider, you are doing cost data collection, but not like ground ambulance. And I'll leave this presentation with you and you will have it, but they are, and I'm just going to show you what they are actually responsible for doing. And this was a rule that came out. And they are working on this process. And from my understanding, there should be something sent out about the same time the cost data collection tool is released for ground. We will see something different for air, but it is totally different than the ground ambulance tool. Some of the stuff is the same, but then you've got to do claim level data reporting. So think about every transport that I do for air ambulance, I'm actually going to report on that. I am going to talk about if the patient got a balance, if we balance bill the patient for their co-pays and deductibles, if we didn't, how frequently we appealed, what an unreasonable market concentration we have. What's our market domination? Where are all of our bases located on a map? What's our percentage of the air ambulance of the contracts that we do? It's very granular through the process as well. And then they basically have to come back with a comprehensive report for 2023 data, 2024 data collection back to Congress to let them know what these pieces are. They've got to mandate at least a minimum of these elements that they have found in the aggregate data that was reported by the air ambulance provider. So it's a little different than what ground ambulance is doing. And so it's just interesting, some of these elements that have come out. Now, this is reminiscent to some of us who were on the Hill advocating way back in 2016, 2017, when there was some reporting elements. And when the air ambulance industry was indicating we'll report for, I think, a 20-25% increase. And there's some actually produced documents on data elements that could be looked at. So I find it interesting that some of those data elements are in here that's required or codified into statute on what is being is wanting to be. And sometimes that's why it's say, be careful what you send out or you give out to legislators, because it is then in the public record and it can make and circulate itself around. The other provision that you should note is the notice and consent. So some of you might be hearing about, you know what, I just scheduled outpatient surgery somewhere, elective surgery, and the anesthesiologist called me in and said, we just want to let you know we're not in network with your provider. This is what it's going to cost you for it. This is what they usually pay. You're going to have to pay us for this. We do not recognize, and we need you to sign that you understand that we are out of network and that you are going to pay for. That's what they call notice and consent. And so if there's a notice and consent on file, they actually can be exempted from the provisions of the No Surprises Act, and they can actually make you pay for their full bill charges. Guess what? Air ambulance is not subject to notice and consent provisions. So that means you cannot do that for an air ambulance ride. So you cannot ask any of your patients to waive their balance protections through a notice and consent process, just FYI. But you also do not have to publicly disclose any of the information and requirements to the patients that receive your services like all the other providers are. So they have to actually post that information on their website and then notify the patients when they see them of their provisions. Air ambulance providers are not required to do that, but they also can't do notice and consent provisions. I'm just saying that in general, because if they're doing that with the air ambulance providers, this could be something that they may not allow as well for ground ambulance. And it's going to be a topic of discussion in the Ground Ambulance and Patient Billing Advisory Committee when we start talking about disclosures. Good faith estimates. This is something that the air ambulance has been doing. So somebody calls you and asks you, hey, I want to know how much it costs to go by an air ambulance provider or an air ambulance ride. I got an air ambulance ride going from Houston, Texas to Chicago, and I want to know how much that is. You would have, whether they're insured or not, there are requirements to give them a good faith estimate. And there's certain information that you have to give them. A lot of you probably already do that by the phone. You kind of have a standard, but this actually means that you would actually have to send it up in writing to them as well. So it might change or tweak that process a bit, but you do have to do good faith estimates. This is what I alluded to about the lawsuit that the air industry did with the Department of Health, where they actually vacated that the qualifying payment amount was not presumptive, basically, is what this did as well. But that was a decision that was made as well on July the 26th. It was expected that that was going to happen, similar to what we found out with the TMA, but that was the official notification that happened there. You know, I was telling you guys about some data elements that are out there right now, and you're beginning to see this in the ground ambulance space. If you haven't, it is coming. We are seeing this, especially with United Healthcare using data eyesights.com. Many of you probably know data eyesights. They used to be kind of what I call a single source or a single case agreement, where you might be out of network with somebody, you get some single case agreement that says, well, you accept 20% and we'll pay you in 30 days. And it may have been coming from Data iSight or through like MultiPlan or others. This is a spin-off of that. It's under the same group, but they have now got a user-friendly portal that patients, providers, and payers can use with all of the aggregated data of your transmission files that when you send a claim for payment and your payment files that come back, they have taken all that data and they have actually, you can key in your member number, you can key in your date of transport, you can key in all the information in, and it will shoot it back out to you and it will tell you, you know what? In similar regions, the air ambulance providers in your geographic area, they on average charge this for that rate. This is what Medicare pays for that rate. Here's what we see as a fair and reasonable rate based upon the providers in your area that you should get paid. And guess what they're doing? They're now sending letters to your ground ambulance providers or your ground ambulance patients that you transport and say, you should not pay the bill that is paid to you by, that is sent to you by XYZ ambulance service, because they are 290 times more than what the other air ambulance or the other ground ambulance providers charge in that area. And so they're now trying to use this information to inform their consumers to not pay our ground ambulance bills because we're exempted out. This is something that you should become very aware of right now. There's a lot of us working to try to dispute this, but this is what we're seeing with all this transparency data as people come in. Now we're trying to figure out, are their methodologies correct, or how are they using the QPA function? But these are these type of data that you're looking at right now. If you've not heard of fairhealthconsumer.org, this is another website that you should be paying close attention to as well. And that is another data repository. You can actually click in here as a consumer. You can type in A0427 or an ALS emergency. I can type in my zip code and it will tell me what the average in-network rate is and the average out-of-network rate is and what your out-of-pocket cost will be. So these are different things that they can come in and consumers can begin to estimate what they're being charged as well. So as you can tell, more and more data is coming out. That's just a few of them. There's other ones called the HCCI, the Healthcare Cost Institute. If you remember, some of you, I'm going to jog your memory a bit here, but there was about 10, 11 years ago, there was some when all this transparency stuff, so think the HIE concepts, all of that, there were provisions put out there about transparency and creating what they call these qualifying entities. And you could become a Medicare QIE, and you could apply to Medicare to get claims data, encounter data, all of these use file as an aggregator. And so think like a lot of these places like Fair Health, HCCI, a lot of different data aggregators are now these qualifying. So they're taking all this data and they're beginning to mine it, and they're beginning to look at the data to get it to a consumer in a user-friendly, whether the consumer is the provider, the payer, the patient, and they're beginning to let people know this is what's going on. So this is what we're seeing. This has been happening for 10, 11, 12 years, and now it is the chickens are coming to roost, basically. And so we as a provider community have not been keeping up with all of this as quickly as the health insurers have. And now we're scrambling on the defense, trying to get and see how do we come against, where's our data that we can actually use from an aggregate, not just our data, not anecdotal, but do I have some data repository that is not subjective, but it's an objective data source that I can try to challenge them on this. And this is what you're seeing now happen very quickly. So we're on the defense, unfortunately, and this seems very payer friendly, and it is, but it just also shows that we as a, excuse me, that we as a healthcare community, and especially in the ambulance side as well, we've got a little bit of runway here, but right now they're trying to, there's a definite concerted effort to inform our consumers who we transport based upon their data sets that we might be billing things inappropriately and cost is not factored in right now. And that is where the argument's coming down to, where does cost marry, and where does that delta that we're looking at between what they pay us and our cost, where is that delta and that gap? And we have got to prove that delta. And so that is our issue right now. We had a little conversation yesterday when Tim was bringing up his stuff and kind of working back and forth where we see some of our problems might start to be. So let's talk about ground ambulance, because that really is kind of where most of the stuff, if you're in air ambulance, it's already happening. You are 10 months into this already. And in my opinion, we are just done. We just need to make, how do we make a bad situation a little bit better? And how do we make it a little bit better? And the only way to really show is you're going to have to show access issues are starting to become a problem and people are going to start dying. That is unfortunately where the air ambulance community is. And so we've not started to see that. Typically in our markets, what you usually see is a hospital-based air ambulance service. A base goes down, somebody else fills it in. And so that is going to be what those that are currently under the NSA are grappling with right now, is what are the access to care issues. So let's talk about ground ambulance, because that's most of you in this room. And what should we be preparing for? As I mentioned earlier, that at the 11th hour, literally, it was a few days before this bill passed, Ed and Labor chair basically said and held out, ground ambulance must be addressed in the No Surprises Act. And so the industry grappled really quickly, came up with language on basically moving it to a study request and basically saying there are unintended consequences because of the heavily local regulatory control, and that the majority of the industry, technically 91% of the industry, bills Medicare less than 2,500 claims a year. This is based upon last year's claims file. Medicare claims file is 91% of all ambulance services build the Medicare program less than 2,500 transports. That's important to note. Very small, lot in the rural areas, super rural areas. And so what could this do to the infrastructure and the fabric of rural America and access, without truly studying the impact that the No Surprises Act would have on the ground ambulance industry? So that resonated with Congress, that resonated with our champions, especially Senator Schumer's office. And so language was adopted to insert in to the No Surprises Act that basically said we're going to establish a ground ambulance and patient billing committee. It's going to be a FACA committee, which falls under the FACA rules of how you govern a committee. And then the committee would actually be charged with doing these provisions. So it'd have the oversight of the secretaries, so Health and Human Service, Treasury, and Labor, with the lead agency being Health and Human Services. And it would have a purpose. And I'm succinctly doing this. And you see that I've highlighted balance billing, because we keep talking about the No Surprises Act and surprise billing. And there's a difference. We can debate ourselves all day long. And please don't ask me a question that, it's really surprise coverages. I get it. We're all talking and preaching to the choir here. We've lost that argument at this point in time. The insurance carriers have done a very good job on spinning that we're the bad guys. And that's just because of messaging. But this basically says you've got to look at disclosures. We need to review options to improve the disclosure of charges and fees. So this is what this committee is going to have to do. It's going to have to show better inform the consumers of their insurance options. So basically the insurance carriers have to also disclose what kind of coverages they have, how they pay, things like that. And then it says protect consumers from balance billing. So think about balance billing. Balance billing just isn't billing the patient from the allowable to the bill charge. Balance billing is everything. So we're going to be able to have a discussion about protecting consumers from balance billing that might inure to our benefit as we start working through the processes on what we want to discuss and have the committee really look at in order to educate consumers, whether you're a payer, a provider, a legislator, a state government, whatever you are, to understand we've got a window to be able to educate on who the industry really is. We're more than just lights and sirens going down the road. And so how do we do that? And this is the ability for these purposes as well. The report will have to include recommendations as well. So remember, this is a committee that gives a report. Most of the recommendations that are going to be included are going to take an act of Congress. So just because the committee is standing up and makes a recommendation doesn't mean Congress has to implement the recommendation. There are a few things that they could possibly regulate, and this is where we'll talk about the network adequacy piece. That could be a regulatory issue as well, but just FYI on that. That is what this committee is supposed to do. It's going to make a recommendation. It's going to be into a formal report that individuals can use in order to address this issue. So it is a committee. It's going to be our first formal report that ever has happened on our industry outside of a GAO study or a MedPAC study or some commission study. This is actually the first in a committee that's under the FACA side that is actually addressing this. So we should use this to our advantage as well. I don't care where you're from the consumer perspective on educating how this actually works. Now, what are my recommendations that I believe ground ambulance, this advisory committee should look at? Don't reinvent the wheel. Remember, we are still budget dust. In the broad scheme of things when you're looking at it. So for Congress, if you come back with a recommendation to Congress to say, we want you to just redo all this and do everything and they were going to have to basically write new rules, all of that kind of stuff for a small finite piece of the budget, and it's going to cost a lot of money to do. The likelihood they'll disregard the report and just insert you into the No Surprises Act. That's what we're trying to avoid. So literally, what are the key elements that we should look at that are most impactful? It's the 80-20 rule. Most of the issues centers around the qualifying payment amount and the independent dispute resolution criteria. That is something that we should be paying close attention to through the process. So those are the two elements that I would suggest. And then we need to consider a few of these elements. But the one key that we've got to take a look at, guys, is to make sure that all of our recommendations we are doing through the lens of the consumer, not the provider, not the insurance carrier, because that is what they're looking at. How does this impact John Q. Citizen? Okay, does John Q. Citizen really care what type of organizational ambulance picks them up? Do they care it's a fire department? Do they care if it's a government, a city, a county system? Do they care if it's a private? Do they care if it's a private equity? Do they care if it's a hospital? John Q. Citizen just knows if I need an ambulance and I call 911, I want them to show up. And if they show up in 2 minutes and they're having a heart attack, it felt like 10, they're going to get mad. That is the lens that we've got to see everything through when we're structuring our arguments. And so we've got to understand state and local regulatory controls. That is very important. And there's going to be a lot of discussion around that and how locally regulated are our dispatch systems? How do we triage calls through the process? How does that look like? Are there certain incentives for people? Is there certain areas where you got to pay for dispatch? Is there certain areas where there's penalties associated for certain response times or running hot, whatever it is? That's all going to come out on what does the EMS industry look like? What are those state regulations that control? What are the local regulatory controls of that? What does that look like? Organizational structures are going to come up. What's different between each organizational structure? How does a public utility model work differently than a private public partnership? It works differently than a fire department. It works differently in rural areas, frontier states, urban areas. What's that look like? And then we're going to have to answer the question, why aren't we a utility model? If everybody thinks that they have access to EMS or 911, why isn't it funded like water, electricity, the police, the fire department? Why isn't it a utility model? We're going to have to answer that question because that question comes up all the time when you're talking to regulators. It comes up all the time when you're talking to CCIO, which is the entity that is going to be the consumer, that is the consumer entity that is within CMS that is actually has oversight over these provisions. And it comes up all the time. Why aren't you guys a utility model? Why aren't you treated like, why aren't you funded like that? That's going to come up. And then network adequacy is a very interesting conversation that has come up, especially in the last 6 to 7 months, on, you know what? Ambulance has never really been looked at federally from a network adequacy piece. And yeah, for Medicare beneficiaries, MCOs and others should have to be able to prove that they've got adequate coverage or adequate networks. Now, network adequacy doesn't give you a sure benefit to say, oh, well, you're going to have to pay me my bill charges because I'm the only one, I'm a sole source 911 provider. No, basically has parameters surrounding around it that basically says you have to have at a minimum a percentage of your claims that are paid as in network. And if you don't, you have to be able to prove why you don't have an adequate network. And if you can show that you've tried to enter into good faith negotiations with providers and they are strong arming you or whatever like that, then you can get exemptions to that 70-30 rule or 75-25 rule. So depending upon like Medicare, Medicaid, some states all have different network adequacy rules when it comes to insurers. Insurers hate network adequacy rules, just so you know. Providers love them because it gives them another negotiation chip or bargaining chip through the process. That is something that they're going to look at. So every state has a network adequacy rule, but unfortunately, it doesn't typically address EMS. It'll address your physicians, it addresses hospitals, and it's a very contentious, and it's usually found in your insurance code. Medicare addresses network adequacy and for managed care as well, but it doesn't address ambulance in the network adequacy rules. That's not covered in the network adequacy rules. And so that is something that we need to look at as well. I know there is there's going to be a whole section that's going to review stuff like that as well. So this is another area that we need to consider to make sure we bring to light that says this is another area within EMS that while we are paid similarly to like suppliers and physicians and other healthcare providers, the same provisions don't apply from an adequate network, things like that as well. That we do responses and don't get paid for. That the only way that we typically get paid for the most part from Medicare and Medicaid is if you transport a patient into the hospital, except for the pandemic. There are some insurance carriers that may pay for certain responses. But what about if a beneficiary calls us and while we're on our way to while we're on their way to go get the patient, they cancel the call? There's not like a fee that's charged, or there's not a fee that's paid by the provider or paid by the payer as well. So those things will come out as well to kind of talk through and paint the picture. And should those factors be considered if you are going to dispute the amount that they pay you as a qualifying payment amount? Now, I know this is going to be a little controversial as well, even within our own industry. But on the qualifying payment amount, should we consider putting in a floor? That floor is not in there currently for any of the other provider groups. And that seems to be an issue that is resonating right now, in especially like the smaller physicians that don't have the adequate coverage to do that, is maybe that they should have considered a payment floor. And what I'm saying is maybe there should be a payment floor that says we should get paid 300% of Medicare at a minimum. And then if we want to dispute from there because of other factors, then we go to IDR. But at a minimum, this should be done. These are things that are going to need to be talked about in the qualifying payment amount. Should we be looking at things like that through the process? If you have not signed up, and I believe I've got 10 more minutes here. If you do not sign up, you need to do this right now to the cms.gov no surprises. I'm strongly suggesting, I've got some more time. Good, I'm not rushing here. If you have not signed up for this already, even though it doesn't apply to you as a ground ambulance, you should at least sign up for the notifications, not everything, but at least the summary of changes that are being made, because it'll keep you abreast of this. You will get this PDF, guys, as well. And it is also on that QR code that you downloaded yesterday. You'll see it in there. These are all hot links. And if you just click on the hot link, it'll take you right to the site. But I would strongly suggest you sign up for their listserv to at least get the overview stuff that's happening. So you can kind of stay on top of what is going on right now. More information. It's very overwhelming right now. So you're going to have people like us, like me and others, that are going to try to keep you guys abreast of things that you really need to know about right now, and try to break it down for you into terms that you can understand, or at least apply to you as a service. But strongly suggest you stay on top here. Here's where most of the interaction is going to be happening. Like if you want to get into the dispute process with someone, you're going to have to do stuff through this site is where you're going to do a lot of that. The selection of the entity that you want to use, things like that is where this is where you're going to do everything as well. So I'm going to turn it over because I know a few of you had questions, and I don't know, Tim, if I answered your network adequacy question as well, but we can have some more dialogue through this and see what questions that you guys have right now.
Jim, go ahead. So, Asbel, I was wondering, because even in some of your earlier slides, you mentioned about previous state rules, and I know we've had conversations about this in the past, even you and me on the phone earlier in the year. How does the New Surprises Act, or what's going on, impact our current rule regarding ambulance payment in Colorado, 3 CCR 702-4?
So let me go through how the No Surprises Act is going to impact state law. If your state law actually is binding, it is going to supersede the provisions of the No Surprises Act. So ground ambulance is actually implemented into the No Surprises Act on the federal side. Right now it is not. So basically the state rule doesn't apply. It's only going to apply to the things that are governed under the state law. But still the ERISA plans are not there. So that's 51% of all the lives in Colorado are not covered under your state law. Okay, once ground ambulance gets into the No Surprises Act, so I'm just saying they're going to have to address it one way or the other. They're either going to say, insurance carriers, you got to pay whatever the local rate says. That is binding. Okay, if they say that, then basically every locality that has their rates mandated by the local governing entity, the insurance carriers are going to have to pay that rate. Now, the state can come in and say, we're going to now include, and as long as I have something binding, the state law could preempt the federal law. And so that is the thing that you've got to include the federal law in first for the state to trump. So they've got to do something with this. They've got to either give authority to the states to govern ERISA plans for a ground ambulance service, but they've got to give the authority to the states to govern that. And that's only going to happen with the inclusion of some provision into the No Surprises Act. Until that happens, anything that is passed on the state level that concerns ground ambulance services is only going to cover those lives that are governed under the insurance code, and it excludes those under the ERISA plans. Does that answer your question?
So, and just make certain I understand it, the answer, understanding right now that this rule only impacts the Colorado plans. It does not include the ERISA plans. I get that. When No Surprises is addressed for ambulance at the federal level, will this rule be the rule for ERISA and state?
That would only, that will only happen. Yeah, that will only happen if the state comes back and modifies or whatever their state. So that's what you see happening now. So you see a proliferation that they're going, if the state has already addressed rates and the IDR process to make it binding, because there are some that the states address balance billing, but providers can still balance bill them if they go through a mediation process and they can't agree on it. And so the mediation process is not binding. And so the patient still stays in the middle. Okay. There's some where there is an arbitration process or it's baseball style and it is binding. And so if it's binding, then that state law will preempt it. So it has to meet those minimum specifications because there are some state laws that it is binding already. on all of even the ERISA plans now. But then there are some they've got to go back and modify. There are some where, for instance, I'm going to use the state of Texas because they have a law, but unfortunately what they didn't do is put a cap on the rates of the arbitrator. And so the arbitrator's rates now are in the $3,000 a claim. Well, for most small providers, if your numbers aren't in the aggregate and you're not batching it, it makes no sense for you. You're going to pay more for the arbitration than you are for the actual claim. And so a lot of them aren't using it, and that will be addressed in the provider community is in uproar. They didn't think about that. They didn't think about the raising costs. On the federal level side, there is a cap to what the arbitrator can charge. And that you can also batch claims as well through the process. So you're seeing some states that have addressed this, that have binding legislation already, that are going to modify certain provisions, but the state law does apply. If you've got something similar, and I haven't checked your whole state, you probably know, Tim, more than I do. You guys have been eating, living, and breathing that. Once you include it, once it is included in, and your provider types are included in, your state law will preempt the feds, because that's what they originally want. The feds didn't want to do this anyway. It was the only reason why they had to address it is because ERISA plans were not included and the federal health plans were not included. So they're now including it and allowing it. And they're basically saying, if there's a state regulation that already does this, then this will apply. If your state doesn't do this, then the federal law will apply. And that's regarding the recognized amount, and that is regarding the IDR process.
So is there then do you have recommendations that maybe states should do preemptively to prepare for this? Is there anything we can do?
So I am not opining on that right now, Tim. I know a lot of people are wanting that. I'm not opining. I have been pretty resolute at this point saying, wait for the federal thing to come out, because we don't know where that's going to land. Unfortunately, the Ground Ambulance Advisory Committee is not standing up as fast as we had thought it was going to. And so it's probably going to be middle of next year before the report comes out. And that way we'll see what the recommendations are, because what you don't want to do is make it so restrictive on you in a state, and the federal side is much more in favor of what you want, and then you've got to go and do something. But some states are not allowing that, so some providers are having to go. So if you get to that predicament, then I'm more than happy to opine in the 11, like what you should be considered if you don't have the ability to continue to stall it. But at this point in time, I'm not really making a recommendation.
Any other questions in the room?
Don't you love that political response, Tim? Sorry.
I know, because right now in Colorado, publicly funded agencies are exempt from the balance billing rules.
I am telling, just from what I've seen anecdotally across the nation, a lot with either providers I'm working with, data that we've been aggregating as well on our side, and stuff that we're beginning to see is that really serious consideration needs to be debated around creating a floor. And creating a floor on the QPA.
Is that what we did in Colorado with the 325% for the non-government entities? Did we create the floor, and should we apply that floor to both the public and the private, so it's already there?
That's going to be a debate that you're going to have to go through, whatever, as a community. But I am, just based upon data that we're seeing as well, is that serious consideration needs to be given to creating a floor. And these are some of the lessons that are being learned by other providers that are under the NSA. Not necessarily all specialty types, but some specialty types that you're talking to and that I'm talking to are really reconsidering that whole decision of not really advocating more for it. That's about all I'm going to say on that, and I'm going to get 2,000 emails if you guys send this email out where everybody can access it. I'm going to get a lot of emails and texts like, why did I just say that? But I mean, literally, you really need to give serious consideration to it.
Can you define the ERISA plans? I'm not sure everybody understands the difference between those federal.
Sure, that would be, so think about it from this perspective, and thanks for bringing that up. Perspective, a large employer, mid-level employer, even some small, they're doing co-op type of people get together, whatever, but it's basically those that are funded by the employer. So Amazon, all of the employees that work for Amazon, the company has its own self-funded plan. It may use a third-party administrator like Blue Cross Blue Shield to administer the plan, but they are paying for all of the healthcare claims of their employees. And they usually have like stopgap insurance policies that help them augment, like the first claim payout up to $100,000 or $1 million is paid for by the employer directly. And then a stopgap insurance policy on the back end kicks in. But that is what we're talking about. Those are all governed under ERISA. Or is those self-fund type plans like that. And that is mainly the majority of Americans that work for very large employers or employer type groups. Most of them do work under those type of ERISA funded plans. Now, you're starting to see that become more popular even with small businesses that work within a consortium of providers that might be a self-funded policy that has a stopgap behind it, and they're kind of pulling all their resources together. For instance, Solutions Group, our employees, that's what we just put into place as well. And so it's technically the employees of Solutions Group are also employed under an ERISA funded plan. But typically like a middle market.
ERISA plans are regulated at the federal level, correct?
That is correct. At the federal level, and it's very, I will tell you, at the federal level, it's very loose, the regulations that govern ERISA, just so you know. It's not anything like the state insurance commissioners and your legislative bodies regulate under your insurance code for all the other plans. So think, you know, if you're self-employed and have a plan with Blue Cross, it's going to be a mid-level lot of mid-level market plans, major medical plans, things like that. Those are typically those that are governed by the state.
And the reason I asked for that was because I think you mentioned 51% are ERISA plans in Colorado. Like if the company sends the check to the patient, you can only complain to the insurance commissioner for those who are non-ERISA plans.
Correct.
That is correct.
And as you know, good, because the state has no control over it.
Correct.
That is correct. I will tell you some of the success that providers are having as well is going to your large employers in your state. And this could be something that an association could do, a RETAC that would say, you know what, for the large employers here, they're paying an unreasonable rate to the access of service. There's a lot of us that have done that, been very successful with getting large employers. And then what happens is the large employers come back, oh yeah, we should be paying more for this. And they help change that, the plan is whatever. Some people have been very successful with like mobile integrated health and CP, instead of going directly to the carrier, going to that actual entity. So if it's an Amazon, or if it's whatever that large employer is in your neck of the woods, you might want to sit down with that large employer's HR department and talk to their HR VP or their CEO, CO, whoever it is. Typically it falls under the HR or CFO, and talk them through how you can provide savings to them, access more to their patients, things like that. That's also an avenue that you're beginning to see more. You're beginning to see employers take over their healthcare. It's why you saw Amazon get into the business. Apple, all these big companies now are starting to get into the business of regulating their own health, because they're noticing our premiums aren't going down. These TPAs, these third-party administrators like Blue Cross, Cigna, United, that has gotten into, they're not managing our dollars appropriately. And so that's why you see more active engagement there. So it's just interesting what's beginning to happen now.
Are there any questions online? I don't see any hands up. Any other questions here in the room? Looks like you've covered it for us today, Asbel. Appreciate it.
Perfect, guys. Y'all
Thanks, Asbel.
have a good week. All right.
I'll get
Bye-bye.
the slides out after you get them out to me.
Will do. All righty.
Thank you, Asbel.